Your child's brain is worth $3,400 per year to pharmaceutical companies. That's the average revenue generated by a child diagnosed with ADHD, depression, or anxiety. Conditions that barely existed 30 years ago but now affect 1 in 6 American children. In 1987, 500,000 American children took psychiatric medications. Today, over 8.4 million kids are on mind-altering drugs. A 1,680% increase that cannot be explained by better detection or medical advances. Normal childhood behaviors, energy, defiance, sadness, questioning identity have been transformed into billable disorders with patentable treatments. The result is the largest uncontrolled experiment on developing brains in human history. Children who start psychiatric medications rarely stop. The drugs create dependency, withdrawal symptoms, and psychological reliance lasting decades. This isn't medical treatment. This is customer acquisition conducted on children who cannot consent, resist, or escape. Stage 1. Redefining childhood as pathology. The transformation of normal childhood into medical pathology began in 1980 with the publication of DSM-3, the Diagnostic and Statistical Manual of Mental Disorders. This edition expanded mental health diagnoses from 180 to conditions to 265, including new categories specifically targeting childhood behaviors. The ADHD explosion. ADHD diagnoses increased 3,000% between 1987 and 2000, but diagnostic criteria include often fidgets, often leaves seat, often runs about, normal childhood behaviors that were healthy until profitable to treat. The process requires no brain scans or objective measurements. A teacher's assessment and parent questionnaire can result in lifelong psychiatric diagnosis and immediate pharmaceutical treatment. ADHD symptoms perfectly match effects of modern educational environments. Children forced to sit motionless 6 to 8 hours daily, deprived of physical activity, overstimulated by digital devices. Instead of changing toxic environments, the medical establishment drugs children to tolerate them. The depression epidemic. In children, childhood depression diagnoses increased 600% since 1990, with antidepressant prescriptions for children under 12 doubling every 5 years. But childhood depression was virtually unknown before pharmaceutical companies developed pediatric antidepressants. Symptoms include sadness, irritability, difficulty concentrating, normal responses to stress that previous generations addressed through family support and time. Modern criteria pathologize normal emotional responses to abnormal situations like divorce, school pressure, or social media bullying. The anxiety disorder expansion. Childhood anxiety disorders have increased 400% since 2000, with social anxiety, generalized anxiety, and separation anxiety becoming common diagnoses for children as young as 3 years old. The expansion of anxiety diagnoses coincides with increased social isolation, reduced outdoor play, overprotective parenting, and constant digital stimulation, all environmental factors that naturally create anxiety in developing nervous systems. But instead of addressing the environmental causes of childhood anxiety, the medical system treats the symptoms with benzodiazepines and antidepressants that create physical dependency and prevent children from learning natural anxiety management through experience and development. Stage 2. The school-to-prescription pipeline. Public schools have become recruitment centers for pharmaceutical companies through policies that identify problem children and channel them towards psychiatric diagnosis and medication. Teachers with no medical training are trained to recognize symptoms of mental illness and refer children for evaluation. Teacher training programs. Pharmaceutical companies fund teacher training programs teaching educators to identify psychiatric symptoms in normal behaviors. Teachers receive continuing education credits for pharmaceutical-sponsored workshops on recognizing ADHD, depression, and anxiety. The training creates bias toward medical explanations while discouraging examination of classroom management or environmental factors causing student difficulties. School counselor pharmaceutical partnerships. School counselors increasingly recommend psychiatric evaluation for students experiencing academic or behavioral challenges. Counseling departments receive funding and resources from pharmaceutical companies that promote medication as first-line treatment for childhood emotional problems. School-based mental health programs often include pharmaceutical company representatives who provide education about childhood mental illness and treatment options. These programs normalize psychiatric medication while presenting drug treatment as routine healthcare. The partnerships create financial incentives for schools to identify mental illness rather than address educational inadequacies, social problems, or family issues that might be affecting student performance. Zero-tolerance policies and medical referrals. Zero-tolerance disciplinary policies increasingly result in medical referrals rather than traditional consequences. For behavioral problems, students who violate school rules are sent for psychiatric evaluation rather than addressing the underlying issues causing their behavior. This approach transforms school discipline from educational opportunity into medical pathologizing that labels children as mentally ill for normal, developmental challenges, and social conflicts. The IEP drug pipeline, individualized education programs IEPs, for special needs students increasingly require psychiatric diagnoses and medication compliance as conditions for educational accommodations. Children cannot receive learning support without accepting mental illness labels and pharmaceutical treatment. Parents desperate to help their struggling children are forced to accept psychiatric diagnoses they don't believe in order to access educational resources. The system makes medical pathologizing mandatory for educational assistance. Stage 3. The pediatric prescription process. The process of prescribing psychiatric medications to children has been systematically simplified and accelerated to maximize pharmaceutical sales while minimizing medical oversight and parental resistance. The 15-minute diagnosis. Pediatric psychiatric diagnoses require one 15 to 30-minute appointment with family doctors, pediatricians, or nurse practitioners with minimal child psychology training. The process relies on standardized questionnaire from parents and teachers rather than comprehensive evaluation. Children are rarely interviewed directly. Diagnosis is based on adult observations rather than the child's actual mental state or experiences. Off-label prescribing to children. Most psychiatric medications prescribed to children are off-label, never tested for pediatric use. Children receive powerful drugs based on adult studies with no relevance to developing brains. Long-term developmental effects are unknown. Off-label prescribing enables pharmaceutical companies to expand adult drug markets without expensive pediatric trials. Children become test subjects for medications that may cause irreversible developmental damage. Polypharmacy, the multiple drug approach. Children diagnosed with mental illness frequently receive multiple psychiatric medications simultaneously, a practice called polypharmacy that has never been studied for safety or effectiveness in pediatric populations. A child diagnosed with ADHD and anxiety might receive stimulants, antidepressants, and stabilizers concurrently, creating drug interactions and cumulative effects that no researcher has ever examined in developing brains. Polypharmacy typically begins when initial medications cause side effects that are treated with additional medications, creating cascading prescription regimens that can include 4 to 6 different psychiatric drugs for a single child. The dosage escalation trap. Children who don't respond to initial psychiatric medications receive higher doses rather than reevaluation of the diagnosis or consideration of non-pharmaceutical alternatives. Dosage escalation continues until either the child shows behavioral compliance or experiences severe side effects. The escalation process assumes that medication non-response indicates insufficient dosing rather than inappropriate treatment, misdiagnosis, or environmental factors that pharmaceutical intervention cannot address. Children who develop tolerance to psychiatric medications receive increased doses throughout childhood and adolescence, creating drug dependency before their brains finish developing. Stage 4. Creating lifelong customers. The ultimate goal of pediatric, psychiatric medication is creating customers who remain on psychiatric drugs for decades. Children who start psychiatric medications rarely discontinue them because the drugs create biological and psychological dependencies that make stopping extremely difficult. Brain chemistry alterations. Psychiatric medications alter neurotransmitter systems in developing brains potentially permanently. Children's brains are forming neural pathways. And pharmaceutical intervention during critical periods can prevent normal maturation. Stimulants alter dopamine systems regulating motivation and attention. Antidepressants alter serotonin systems before full development, potentially preventing natural emotional regulation mechanisms. Withdrawal dependency. Children who try to discontinue psychiatric medications often experience severe withdrawal symptoms that are misinterpreted as return of the original mental illness. This creates the false impression that the medications are necessary for normal functioning. Withdrawal from ADHD stimulants can cause fatigue, depression, and attention problems that are worse than pre-medication baseline. Children and parents conclude that the medication is necessary when the problems are actually caused by drug discontinuation. Antidepressant withdrawal in adolescence can cause suicidal thoughts, emotional instability, and cognitive problems that last months or years. These symptoms are often treated with additional medications rather than recognized as withdrawal effects. Psychological dependency and identity formation. Children who grow up taking psychiatric medications develop identities centered around mental illness and pharmaceutical management. They learn to attribute their abilities, emotions, and behaviors to medications rather than developing self-awareness and internal regulation skills. Adolescents who have taken ADHD medications since childhood often cannot imagine functioning without drugs. Their identity includes being a person who needs pharmaceutical assistance to concentrate, learn, and behave appropriately. The psychological dependency extends beyond the individual to family systems that organize around medication schedules, dose adjustments, and medical appointments. Family life becomes structured around pharmaceutical management rather than natural childhood development. Educational and social reinforcement. Schools and social services reinforce pharmaceutical dependency by requiring medication compliance for educational accommodations and behavior support. Children learn that academic and social success depend on pharmaceutical intervention. College students who were medicated throughout childhood often increase stimulant doses to handle academic pressure, beginning patterns of prescription drug abuse that continue into adulthood. The educational system creates environments that require pharmaceutical intervention to tolerate, then uses medication compliance as evidence of responsible self-care and medical necessity. The financial engine. Follow the money the pediatric psychiatric medication market generates. $13.8 billion annually, with average lifetime customer value exceeding $150,000 per diagnosed child. Understanding the financial incentives explains why childhood mental illness diagnoses continue expanding despite lack of evidence for improved outcomes. Pharmaceutical company strategies. Companies invest heavily in expanding pediatric markets through direct advertising targeting parents with messages about helping children succeed and manage difficult behaviors. Ads present medication as loving support rather than pharmaceutical intervention. Medical conferences receive funding to promote pediatric diagnosis. Doctors attend expense-paid seminars presenting childhood mental illness as undertreated emergency requiring aggressive pharmaceutical intervention. Doctor financial incentives. Physicians receive financial incentives for psychiatric medication prescribing through speaker fees, consulting payments, research funding, and pharmaceutical company partnerships. These payments influence prescribing practices even when doctors don't consciously recognize the bias. primary care doctors can generate significant revenue from psychiatric medication management. Because these appointments require minimal time investment but generate high reimbursement rates from insurance companies. Psychiatric specialists build practices around childhood medication management, creating steady income streams from patients who require ongoing prescription, monitoring, and dose adjustments for years or decades. Insurance company complicity. Insurance companies promote pharmaceutical treatment for childhood mental illness because medications are cheaper than comprehensive psychological evaluation, family therapy, educational support, or environmental modifications that might actually address underlying problems. Insurance reimbursement policies favor quick psychiatric diagnosis and medication prescribing over time-intensive evaluation and non-pharmaceutical intervention. A 15-minute medication appointment receives full reimbursement, while comprehensive evaluation and therapy face coverage restrictions. The insurance system creates financial pressure for rapid diagnosis and pharmaceutical treatment, while making alternative approaches economically impossible for most families. School system financial benefits. Schools receive federal funding for special education services based on the number of students with diagnosed disabilities, creating financial incentives to identify mental illness and learning disorders that qualify for additional resources. Students with psychiatric diagnoses generate higher per-pupil funding while requiring minimal additional educational investment if their conditions are managed through pharmaceutical intervention. The funding structure rewards schools for identifying mental illness rather than creating educational environments that support natural childhood development and learning. The international comparison: why American children are different. American children consume 80% of world psychiatric medication production, despite representing 4% of global child population. This disparity reveals pediatric psychiatric medication is primarily American phenomenon with cultural rather than medical explanations. European countries emphasize family support and educational modification before psychiatric diagnosis. Children receive comprehensive evaluation, including social and family factors, rather than focusing solely on symptoms. Cultures maintaining traditional child rearing, extended family support, and age-appropriate expectations have virtually no childhood psychiatric medication, despite facing poverty and stress. Educational system comparisons. Educational systems that allow later academic starts emphasize physical activity, provide outdoor education, and accommodate different learning styles have significantly lower rates of ADHD diagnosis and medication use. Finnish children start formal academics at age 7, have frequent outdoor breaks, and receive individualized learning support without psychiatric pathologizing. Finnish children have among the lowest rates of childhood psychiatric medication in the developed world. American educational systems that force early academics, eliminate recess, reduce physical education, and standardize learning approaches create environments that require pharmaceutical intervention for many children to tolerate. The long-term consequences: what we're creating. The generation of children raised on psychiatric medications is now reaching adulthood, and the long-term consequences of mass childhood pharmaceutical intervention are becoming visible. The results suggest that pediatric psychiatric medication has created more problems than it solved. Developmental delays and learning impairments. Young adults who took ADHD medications throughout childhood show delays in emotional development. Socialski, an independent pair who developed without pharmaceutical intervention. Stimulant medications may interfere with normal brain development processes that occur during childhood and adolescence, resulting in adults who lack internal motivation, attention regulation, and emotional maturity. Long-term stimulant use is associated with decreased creativity, reduced problem-solving abilities, and impaired stress tolerance that persist into adulthood even after medication discontinuation. Addiction and prescription drug abuse. College students who were prescribed ADHD medications in childhood have significantly higher rates of prescription drug abuse, stimulant addiction, and substance use disorders compared to students who were never medicated. Early exposure to psychiatric medications appears to increase vulnerability to addiction by altering brain reward systems during critical developmental periods when addiction susceptibility is established. Young adults report using ADHD medications as performance drugs for work, social situations, and academic challenges, indicating that childhood medical treatment created patterns of pharmaceutical dependency for life challenges. Mental health deterioration. Adults who took antidepressants as children have higher rates of depression, anxiety, and suicidal behavior in adulthood compared to individuals who experienced childhood emotional difficulties but received non-pharmaceutical support. Long-term antidepressant use beginning in childhood may prevent the development of natural emotional regulation skills, leaving adults dependent on pharmaceutical mood management without internal coping capabilities. Young adults who discontinue childhood psychiatric medications often experience emotional instability, identity confusion, and mental health crises as they attempt to develop personality and emotional skills that pharmaceutical intervention prevented from forming naturally. Social and relationship difficulties. Adults who were medicated throughout childhood report difficulties with intimate relationships, social connections, and emotional intimacy that may result from impaired emotional development during critical childhood periods. Pharmaceutical management of childhood emotions may interfere with the development of empathy, emotional intelligence, and social skills that require natural emotional experience and regulation practice during childhood. Young adults who took psychiatric medications as children often struggle to understand their own emotions, needs, and motivations without pharmaceutical assistance, creating challenges in career choices, relationship decisions, and life planning. The alternative path. What children actually need. Most childhood difficulties result from environmental factors addressable without pharmaceutical intervention. Environmental modifications. Children diagnosed with ADHD often show normal behavior with appropriate physical activity, hands-on learning, and age-appropriate expectations. Childhood anxiety and depression frequently resolve with reduced academic pressure, increased family time, and limited screen exposure. Family and community support. Children benefit from strong adult relationships, mentorship, creative expression, and meaningful community contribution rather than psychiatric diagnosis. Developmental understanding. Childhood difficulties are often normal developmental challenges resolving with time, support, and appropriate environments, eliminating need for psychiatric intervention. The choice before us, the pediatric psychiatric medication experiment, has created a generation of chemically dependent adults while generating enormous profits for pharmaceutical companies. The evidence suggests that this approach has harmed more children than it has helped. But the system continues expanding because it serves financial interests rather than children's well-being. Pharmaceutical companies profit from lifelong customers. Medical professionals profit from ongoing treatment relationships. Schools profit from federal funding tied to psychiatric diagnoses. The children bear the costs through altered brain development, psychological dependency, and impaired natural emotional and social development that may affect them for life. Parents face impossible choices between accepting psychiatric labels and medications. They distrust or watching their children struggle in systems designed to require pharmaceutical intervention for success. The choice is becoming urgent as more children enter the psychiatric system each year and fewer alternatives remain available. Once children begin psychiatric medications, discontinuation becomes extremely difficult due to withdrawal effects and psychological dependency. But alternatives exist for families willing to seek educational options, family support, and community resources that address childhood difficulties without psychiatric pathologizing. The pharmaceutical experiment on children is not inevitable. It is a choice being made by adults who prioritize convenience, and profit over children's long-term development and well-being. Understanding what is happening to children is the first step toward protecting them from a system that profits from their dependency and suffering. The children deserve better, and they depending on adults to choose their long-term well-being over short-term pharmaceutical solutions that create more problems than they solve.